Let's deal with the most important immune cell players, B and T cells. Primary organs are responsible for maturation. Where do B cells originate and mature? That's right, bone marrow. Bone marrow makes the B cells. How about T cells? Well, they originate just like all hematopoietic cells in the bone marrow, but they mature in the thymus. The thymus makes the T cells. After B and T cells grow up, they make their way to secondary organs to interact with antigens. Can you list me some of these secondary organs and structures? That's right. We have the spleen, the lymph nodes, the tonsils, and the Peyer's patches. And where are Peyer's patches most predominant? That's right. Terminal ileum.
Hi everyone, let's jump right into our video on the lymph node. Before we talk about the lymph node, we should talk about lymph. What is lymph? Lymph is the fluid in the lymphatic system. But how did it get there? This goes back, way back, to cardiovascular physiology and the Starling forces which determine fluid movement through the membranes of the capillaries. When the forces that push the fluid out of the capillary, which are the capillary pressure and the interstitial fluid colloid osmotic pressure, when those outweigh the forces that push fluid into the capillary, which are the interstitial fluid pressure and the plasma colloid osmotic pressure, then fluid leaks out into the interstitial space, and it gets absorbed into the lymphatic system. What is that term for excess fluid outflow into the interstitium? That's right, it's edema. So what exactly does this lymph do? It acts as a recycling system for fluid from the tissues. It gets filtered in the lymph nodes for any antigens. And if an antigen is found, then an immune response can be triggered. Now that we're at the lymph node, and the cell types involved in different areas of the lymph node are the B cells, the T cells, the macrophages, and dendritic cells. Now, as you should be familiar with, the lymph node is one of our secondary immune system organs. What are some of our other secondary lymphoid organs? Yep, you're right if you said the spleen, the tonsils, the Peyer's patches, those are secondary immune system organs too. They all allow immune cells to interact with antigen. So here's a picture again of a lymph node. If the title on this slide didn't say lymph node, would you consider any other organ? Well, I don't know about you, but it sure looks like a kidney to me. And there are some things in common with the kidney. Just as there is a renal artery and vein, the lymph node is also supplied by an artery and vein. Just as there is a renal capsule, the lymph node also has a capsule, which extends into the lymph node to form trabeculae. Also, when we talk about renal blood flow, which goes from the renal artery, eventually to the afferent arteriole, to the glomerulus, and the efferent arteriole to exit the glomerulus, well, rather than blood, the lymph travels through similar afferent and efferent lymphatics, just as you can see labeled here. As you see, there can be many afferents, but there could just be one or maybe more efferents. There's the one efferent lymphatic over on the right-hand side. So just like when we talk about the glomerulus, the A in afferent should make you think of arriving, and the E in efferent or efferent should make you think of exiting. As we talked about on the last slide, the lymph node has macrophages, part of our innate immunity, so they function for nonspecific filtration of antigens. The lymph node also stores both our B and T cells, and if it has to, it can activate the immune response. As lymph drains past the capsule of a lymph node through the afferent lymphatics, the first thing it encounters are follicles within the cortex. The B cells are localized in the follicles, and they proliferate in the outer cortex. In this image, we can see that the follicles are initially solid purple, and they're called primary follicles, which are dense and dormant. If the B cells encounter pathogens and are activated, the follicles develop a light-colored center, or germinal centers, as we see in the image, and they are known as secondary follicles. Once a B cell matures, it can serve as a plasma cell and secrete antibodies into the bloodstream to defend against pathogens. The medullary component of a lymph node consists of cords and sinuses. The medullary cords, as pointed out in the picture, consists of closely packed lymphocytes and plasma cells. The medullary sinuses, as pointed out here in the picture, communicate with the efferent lymphatics, so the exit system of the lymph node, and these contain reticular cells and macrophages. Now, between the follicles and the medulla is the paracortex. The paracortex houses the T cells. The way I like to remember it is the mnemonic BFTP. So B cells in the follicles and T cells in the paracortex. Or BFTP, my boyfriend needs toilet paper. The paracortex also contains high endothelial venules, where T and B cells enter from the blood. Now that we know what's in the paracortex, can you think of a condition in which the paracortex of the lymph node may not be well developed? You're right if you're thinking of a T cell deficiency, like DiGeorge syndrome. On the other hand, can you think of a condition in which the paracortex would enlarge? You're on the right track if you're thinking of something with an increased amount of T cells, like in a viral infection. Do you remember the pathology term for an increase in the number of cells in a certain area, such as the T cells in the paracortex of the lymph node? Well, yeah, it's hyperplasia. So in viral infections, there's an increased number of T cells and paracortical hyperplasia, and this will manifest as lymphadenopathy. So let's test some concepts with a histological image. What do you think is the area that's covered with the box on the top right? You're right if you're saying that's the germinal center of a secondary follicle. What about this next one with the arrow coming out of it? Yep, that's the mantle zone of a secondary follicle. And what about this last one? This is the space between the follicles and the medulla, and that's the paracortex. All right, that's it. Thanks for joining me. If you have any feedback or questions, please click on the thumb icon and submit your comments or queries there. Thanks. Hi everyone, this video is all about lymph drainage, so let's get started. How does lymph flow throughout our bodies? We'll answer that right now by briefly discussing what parts of the body drain to which regional lymph nodes. Lymphatic drainage of different regions is important to know because it helps you identify potential locations of infections and malignancies and metastases that feed into the nearest nodes. This image labels the lymph node clusters. In the image, colored in a dark brown, it shows that all the lymph from the right side of the body above the diaphragm is collected by the right lymphatic duct, which drains into the junction of the right subclavian and internal jugular vein. The thoracic duct drains everything left and right side below the diaphragm, and also the left thorax and upper limb into the junction of the left subclavian and internal jugular veins. Because of this, rupture of the thoracic duct can lead to a chylothorax, which means lymph in the thorax. The image also indicates which lymph nodes are palpable with a solid green filled circle and those that are non-palpable with an outline of a green circle. Let's start with 5 of the superior lymph node clusters. The first clusters are the cervical and supraclavicular lymph nodes. These clusters drain the head and neck. What are some head and neck pathologies where you would expect cervical or supraclavicular lymphadenopathy, which you can find on physical exam? If you said an upper respiratory tract infection, infectious mononucleosis, or Kawasaki disease, then that's great. The next set of lymph nodes are the mediastinal lymph nodes. The mediastinal lymph nodes drain the trachea and esophagus, and the associated pathologies are primary lung cancer or granulomatous disease. Our next set of lymph nodes are the hilar lymph nodes. The hilar lymph nodes drain the lungs, and they are associated with granulomatous disease. Can you think of an example of a granulomatous disease? One with elevated serum ACE levels and more common in African American females, which is often asymptomatic, except for hilar and mediastinal lymphadenopathy. Well, here's a chest x-ray and CT of the chest to visualize. You're right if you're thinking of sarcoidosis. Now lastly, for above the diaphragm, let's talk about the axillary lymph nodes. The axillary lymph nodes drain the upper limb, the breast, and the skin above the umbilicus. There are a number of associated pathologies with axillary lymphadenopathy, but we'd like to highlight mastitis and metastasis, especially of breast cancer. Axillary lymph node metastasis is the most important prognostic factor in early stage disease. Now, this group of nodes often gets resected during mastectomy in order for pathology to rule out if there has already been metastatic spread from the primary tumor. So what nerve can be accidentally damaged in an axillary lymph node dissection? Yep, it's the long thoracic nerve. Do you know what muscle that innervates? Yes, it's the serratus anterior. And lastly, how would this patient present? Well, they would have a winged scapula and would be unable to abduct the arm above the horizontal position. So let's continue our discussion to below the diaphragm. The 3 main trunks of the abdominal aorta each has its own separate set of lymph nodes, and they more or less drain the areas which their arteries perfuse. Now, for a quick embryology and anatomy review, we know that the foregut derivatives are supplied by which artery? Yep, it's the celiac artery. The midgut derivatives are supplied by which artery? Yep, it's the superior mesenteric artery. And the hindgut derivatives are supplied by which artery? Yep, it's the inferior mesenteric artery. So since the arteries and the lymphatics match up, the celiac lymph nodes, they drain the liver, the stomach, the spleen, the pancreas, and the upper duodenum. The superior mesenteric lymph nodes, they drain the lower duodenum, the jejunum, the ileum, and the colon up to the splenic flexure. And the inferior mesenteric lymph nodes, they drain the colon from the splenic flexure up to the upper rectum. The associated pathologies for all of these lymph node clusters would include some gastrointestinal diseases, including mesenteric lymphadenitis, typhoid fever, ulcerative colitis, and celiac disease. In this image, I want you to recall the villus atrophy and crypt hyperplasia in celiac disease. And in this image, I want you just to have a gross visual of the ulcers in ulcerative colitis. Now, the para-aortic nodes, those drain the testes, the ovaries, the kidneys, and the uterus, which makes sense since all of these organs have their own arteries that jump off the aorta. The para-aortic lymph nodes are associated with metastasis from the structures that they drain. For the external and internal iliac and superficial inguinal lymph nodes, it's easier to remember if you imagine you're examining a patient supine, so lying down, with his or her feet in stirrups. So with just your eyes, you'll be able to see the anal canal, the skin below the umbilicus, the scrotum, and the vulva, since they're all very superficial. So those areas drain to the superficial inguinal lymph nodes. If you wanted to do a more thorough exam of the lower rectum, the bladder, the vagina, the cervix, and the prostate, those are more internal structures, and thus they drain to the internal iliac lymph nodes. The external iliac nodes are a little more confusing to think about because the nodes are called external, but the structures they drain aren't so external. But they include the cervix, the superior bladder, and the body of the uterus. As you may be able to guess, the external iliac, internal iliac, and superficial inguinal lymph nodes are all affected by sexually transmitted infections. The superficial inguinal lymph nodes can also be affected by cellulitis of the medial foot or leg. Cellulitis of the lateral foot or leg, on the other hand, is drained by the popliteal lymph nodes. So now that we've gone through all the areas, let's do a quick recap. Now these lymph node clusters are very important and high yield for exams. So let's say a patient presents with an upper respiratory tract infection. Where would you expect the drainage to occur? So the patient is likely going to have cervical and or supraclavicular lymphadenopathy. What if a patient presented with a lower gastrointestinal pathology, such as the ileum? Now, it would be likely that there would be drainage to the superior mesenteric lymph nodes. Again, you need to remember your foregut, midgut, and hindgut derivatives. I know we're in the immunology section, but it's a great time to brush up on your embryology and anatomy. So again, these are very high yield, and please know which body parts and regions correspond to their lymph node clusters. Now, it's time to test yourself with this question. A 42-year-old man presents to his physician after discovering a marble-sized nodule on his left testicle while showering this morning. He states that he is currently healthy and his only medication is a statin. Other than his father dying at the age of 71 of a stroke, he has no other significant family history. The patient does not smoke and only consumes a couple of beers on the weekends with his friends. He denies any pain, swelling, or redness of the groin. On physical exam, patient is afebrile, BP is 126/89, and respiratory rate is 18. Cremasteric reflex is intact and the patient does not react when the scrotum is palpated. There is a 2-centimeter nodule noted on the left testicle that is firm to the touch. The organ affected by this nodule has a lymphatic system that drains into which of the following nodal regions? You're right if you said aorta. The kidneys, the ovaries, the uterus, and testes all have arteries which drain into the aorta. So remember that the testes are drained by the para-aortic lymph nodes. All right, that's it. Thanks for joining me. If you have any feedback or questions, please click on the thumb icon and submit your comments or queries there. Thanks.
Just as the lymph nodes are responsible for filtering lymphatic fluid, the spleen is in charge of filtering the bloodstream. The spleen is an organ located in the left upper quadrant. Does anyone remember at what rib level it lies? It typically lies between the left 9th and 11th rib. This is an important point to keep in mind if you ever have a patient that shows up with some sort of abdominal or posterior trunk trauma to that region. The spleen is broken down into sections of sinusoids. Just like lymph nodes, there is a surrounding fibrous capsule. Blood filters into the spleen via arteries and leaves via the veins. This white section is called white pulp and contains follicles with embedded B cells similar to lymph nodes. So if B cells are predominantly found in the follicles, it would stand to reason that these numerous follicles are responsible for a majority of producing what immunologic proteins in our bodies? Yeah, IgM antibody production. Periarterial lymphatic sheaths, or PALs, contain T cells that surround arteries within the white pulp. Blood eventually trickles into the red pulp, where macrophages mechanically filter out senescent RBCs, cellular inclusions, and pathogens. Bacteria with capsules are normally destroyed by the IgM released from the spleen. Do you know what some of these encapsulated bacteria are? They can be remembered with the mnemonic SHINE skis, and this stands for Streptococcus pneumoniae, Haemophilus influenza, Neisseria meningitidis, E. coli, Salmonella, Klebsiella pneumoniae, and Streptococcus agalactiae. However, if there is trauma to the spleen, or someone has sickle cell disease and autoinfarcts their spleen, lack of IgM will allow encapsulated bacteria to proliferate and disseminate throughout the body, causing massive trouble, including septic shock. These patients need to be vaccinated annually as they are much more susceptible to pneumonia and flu. A sign of splenic dysfunction or loss is the presence of these types of red blood cells on a peripheral blood smear. What are these inclusions called, and why are they there? They are called Howell-Jolly bodies. And what are they? Right. They are the nuclear remnants from immature RBCs. Normally, the spleen is supposed to filter out this material. Flash quiz time. What types of bacteria are targeted by the spleen? Encapsulated bacteria. Again, you can remember them using the SHINE skis mnemonic that stands for Strep pneumo, Haemophilus influenza, Neisseria, E. coli, Salmonella, Kleb, and Strep.
Hi everyone, let's get started on our video on the thymus. So, what is the thymus? The thymus is one of our primary immune system organs. And what's the other one? Yes, the bone marrow. And just remember that the T cells differentiate and mature in the thymus because they both start with T. And the B cells mature in the bone marrow because they start with B. As you can see in this image, the thymus is located in the anterior superior mediastinum. And again, it's the site of T cell differentiation and maturation. It is also an encapsulated organ, as you can see in this image. Where is the thymus derived from embryologically? Well, the epithelium of the thymus is derived from the third pharyngeal pouch, which is from the endoderm. Can you name any other structures derived from the endoderm? I hope you can name a few things on this list. The thymic lymphocytes, on the other hand, are mesodermal in origin. I'll spare you from recalling other structures derived from the mesoderm and from the pharyngeal pouches, but it's a good time to review your embryology. Exam writers love making questions that are multidisciplinary. So, like the lymph node, the thymus also consists of a cortex and a medulla. The cortex houses immature T cells, while the medulla contains mature T cells, so mature in the medulla. As you can see in this histological image, the cortex is much denser, and the medulla looks paler, so that's a way to differentiate the sections. So also in the medulla, there's Hassel corpuscles. There are these whorled calcifications, which you can see in the second image, and those are unique to the thymus and contain epithelial reticular cells. Here in this chest x-ray, we see a normal neonatal thymus. Newborn babies need all the immunological help they can get since they're still developing. The buzzword is sail sign, or that there's a sail shape on the chest x-ray. Honestly, to me, it looks like there's a bird sitting on the diaphragm and the little sail looks more like a bird's beak, but maybe the achalasia buzzword makers took bird's beak first. So normally the thymus, it involutes with age. But what happens if we see a baby with an absent thymic shadow or a hypoplastic thymus? Well, if that's the case, we should highly suspect an immunodeficiency, especially if the baby keeps suffering from infections. Consider severe combined immunodeficiency or SCID and DeGeorge syndrome. There can also be a neoplasm of the thymus, and in that case we call it a thymoma. Thymomas are often associated with myasthenia gravis, superior vena cava syndrome, pure red cell aplasia, and Good syndrome. In this first image, we see a classic case of superior vena cava syndrome, when something is obstructing the SVC and blood is having difficulty draining from the head. So it typically presents with facial plethora. That's why there's blanching after fingertip pressure. In this other image, you can see the mediastinal mass. Again, normally the thymus involutes with age, but if you see a well-defined, lobulated tissue density, and especially in a patient with myasthenia gravis, then you should suspect a thymoma. And just in case you're wondering, Good syndrome is a very rare combined B and T cell immunodeficiency in adults. And Dr. Robert Good made the association of immunodeficiency and thymoma in the 1950s. All right, that's it. Thanks for joining me. Please give this video a thumbs up if you liked it, and it will give you the opportunity to submit a comment if you have any feedback or questions. Thanks again. Study hard. Hi everyone, this is our lecture on innate versus adaptive immunity. So let's get started. Let's say that a 6-month-old male infant is brought to his pediatrician by his parents for his immunizations. His parents ask why their child needs another dose when the infant received a vaccination for the same thing at their last visit. How are you going to explain this to them? So our learning objectives for this lecture are to be able to differentiate the components of innate and adaptive immunity and to compare and contrast the mechanisms of innate and adaptive immunity. Before we get started with fancy immunology terms, let's just appreciate where we are for a second. You've made it to preparing for step 1. You're sitting and watching this video, maybe putting notes in your first aid. But let's say you drop your pen, or one of the highlighters near you, or your book, and you go to get under your chair and you see a snake. Well, what would you do? I don't know what you would do, so I'll just tell you what I would do. I would absolutely freak out. I'd jump off the chair, I'd scream, I'd throw something at it, and I'd frantically look around me for anything useful. I'd go run to get a broom or open a door, or I'd just get a giant bowl and try to trap it. Okay, let's say somehow you successfully get this snake away from you. What are you going to do? Well, you can't keep studying now. What if it happens again? Personally, I'd go to the store and get some stuff to help me seal up my doors and windows. I'd make sure there's no food laying around. I'd study with a trash can or a bucket next to me in case I need to trap it again. Because I need to be ready in case there is a next time. I can't afford to lose another hour of studying like that again. Now, before we go on, I understand that some people love snakes and may have pet snakes, and I just want you to know that no snakes were harmed in the creation of this video. Okay, onto the table. We need to compare innate and adaptive immunity. What does innate mean? It's something we were born with. something natural, something intrinsic. Some people are innately amazing at memorizing charts and tables, and some people are innately great at basketball. They only have to put in an hour of work when you have to put in 10. Personally, I am not a natural at either of those things, but I've been able to adapt. Well, what does adaptive mean? It means we encountered something and we learned how to deal with it. So, what are the components of our innate and adaptive immunity? Well, what did I do when I saw that snake? I freaked out and I threw everything that I had around me at it. It's kind of what our innate immunity does. We have neutrophils, macrophages, monocytes, dendritic cells, natural killer cells, complement proteins, and enzymes. They're just hanging around our blood. And they're part of our natural arsenal, our innate defense system. Additionally, we have physical barriers, like our skin, to protect us from offending agents. Where did this all come from? Well, the mechanism of our innate immunity is that it's germline encoded. We were born with it. Well, do I always have these components? Did my parents have them? Will my kids have them? When we talk about resistance in innate immunity, we know that it persists through generations and doesn't change within a lifetime. Our innate immunity is like getting the standard factory model of something. It just comes with it. Well, let's compare these things to our adaptive immunity. While we can get by with the standard factory model, it's nice to have upgrades. In terms of components, our adaptive immunity has T cells, B cells, and circulating antibodies. Remember, our B cells are part of our humoral immunity that recognize and present antigens. Then they differentiate into plasma cells to produce antibodies. But they didn't naturally just do that. They were naive at first, and they needed to get activated once they encountered an antigen to know what to do. How do they uniquely figure out what to do? Well, the mechanism during development to generate a diverse set of antibodies is through VDJ recombination. And again, this depends on the antigens we encounter. Well, what about resistance? It depends on what we encounter, so we know what upgrades we need. So, microbial resistance is not heritable. Okay, let's compare some more characteristics. What about our response to pathogens? Honestly, I could have seen any type of snake, rattlesnake, cobra, garden snake, and I still would have done the same thing. So, innate immunity is non-specific, it occurs rapidly, and it has no memory response. But remember how I said I'd go get a trash can to put next to me so I could cover it up if it ever happened again? That's what adaptive immunity is. Now I've got a defense mechanism that is highly specific and refined over time. It develops over long periods, and it has memory. The response is faster and more robust. Instead of throwing anything I have laying around, I have my trash can. I'm not going to freak out as much. I've seen this snake before, and it's not about to take another hour of studying from me again. When we talk about innate and adaptive immunity, we have secreted proteins that help us in our defense that come from our components. So in innate immunity, we have lysozyme, complement, C-reactive protein, defensins, and cytokines. And in adaptive immunity, we already mentioned the immunoglobulins that are produced. Now, that's basically all we have to talk about. But I think we should highlight some of our key features that our innate and adaptive immunities need to recognize those pesky pathogens. In our innate immunity, we have toll-like receptors that hang out on the membranes of our component cells, like our macrophages and dendritic cells. And they recognize pathogen-associated molecular patterns, or PAMPs, like polysaccharides on the outer membrane of gram-negative bacteria, flagellin, and nucleic acids. In our adaptive immunity, we have memory cells, our B and T cells that got activated. So we have stronger, quicker responses when we encounter the same antigen again. Well, time for a quick quiz. Does innate or adaptive immunity have a non-specific, rapid response to pathogens? You're right if you said innate immunity. Good job. How about one more? Are antibodies components of our innate or adaptive immunity? You're right if you said adaptive immunity. Great work. So let's think about this case again. I'm sure some of you are trying to remember the vaccination schedule, and you're right if you're thinking this could be another dose of hepatitis B or DTaP or other vaccines. But this is a pretty common question that parents often wonder. What is the point of giving a vaccine anyway? It's to develop our immune systems to be ready in case it encounters that pathogen again. We're working on our adaptive immunity and our memory so we can have a specific immune response that is faster and more robust against that specific pathogen. So what is the bottom line? Our innate immunity is germline encoded, and so it is nonspecific, occurs rapidly, and has no memory response. Our adaptive immunity depends on exposure to pathogens, and so it is highly specific, faster, and more robust. Well, that's all I have for you here. Please give this video a thumbs up if you liked it, and it will give you the opportunity to submit a comment if you have any feedback or questions. Thanks for joining me. Study hard.
A 3-year-old patient presents to your clinic with fever and a sore throat. As you are asking for the patient's history, the parent asks how her child's body is able to recognize intruder cells and fight off infection. Sometimes having this knowledge will benefit your education as well as the patient's. In this lecture, we will cover identifying the major histocompatibility complexes and what are their purpose, and explaining the differences between MHC1 and MHC2. Now, let's discuss just how certain cells display a piece of a germ, or in fancy medical talk, present an antigen. We need antigen-presenting cells so that when we have come across something foreign in our bodies, a piece of it can be sent to the lab to have it analyzed, so to speak. If it is analyzed and turns out to be a foreign intruder, that's when we have to send in the big gun cells. We have MHCs, which serve as the delivery boys in this process of antigen presentation. MHC refers to the major histocompatibility complex, and the two types are simply named MHC1 and MHC2. Think of one as being the U.S. Post Office and the other one being FedEx. Both are delivering systems that will deliver your package, but with different business models. MHC1 typically presents antigens from intracellular pathogens. Knowing that it primarily functions against intracellular pathogens, do you think it would be more involved in the antiviral or the antibacterial response? That's right, MHC1 is the primary mediator of viral immunity. So these cells are found on all nucleated cells and bind to TCR and CD8. There are 3 subsets to MHC1, each with only one letter, A, B, and C. You can remember that there is only one letter for MHC1. Pretty straightforward. So can you think of a cell type that doesn't express MHC1? That's right, red blood cells are non-nucleated and hence do not express this molecule. It's also important to remember that MHC1 needs a protein called beta-2 microglobulin in order for proper antigen loading to occur. MHC2 receptors are present on B cells as well as cells capable of consuming and degrading pathogens such as macrophages and dendritic cells. They bind to CD4 as well as TCR. There are also 3 subsets, and each of these have 2 letters for MHC2: DR, DQ, and DP. The important protein here is the invariant chain, which really puts a lockdown on the MHC2 system. Okay, so let's go over in detail how each of these presents an antigen. So let's say we have this little virus, and it has recently either been phagocytized or has unwelcomingly entered a nucleated cell. Ubiquitin proteins recognize this as something foreign and attach themselves to this virus. Think of ubiquitin as a bunch of little GPS devices stuck on the sides of this viral particle. It marks this protein for cellular destruction. The ubiquinated particle then gets processed into a proteasome. It gets broken down into bite-sized peptides, which the MHC1 molecule is able to handle. Now here's the kicker. Even though this peptide is loaded onto the MHC, it will not be able to travel to the cell membrane until it gets help from its special protein. You guys remember what that protein was called? Beta-2 microglobulin. Once this protein complex is complete, MHC is able to float up to the cell surface and present this antigen to whatever NK or T cells will listen. Now for the MHC2 mechanism. The way this one is slightly different is that the MHC2 complex is attached to a special protein called the invariant chain. Think of this protein like a bike lock. This bike lock is attached to the antigen binding site, so there will be no antigenic action until this thing is removed. So, how do we remove it? Well, in this particular cell, we have a phagosome, which has already ingested some foreign object and has broken it down into peptides. Within this phagosome, there is a large amount of lysosomal enzymes at work in order to degrade the foreign substance. And this leads to a lowered pH within the phagosome. When the MHC2 complex enters the phagosome, the acidic environment is not favorable to invariant chain binding, and so it frees itself from the MHC2 molecule. This allows the MHC2 complex to bind to one of these foreign peptides, and they finally make it up to the cell surface for antigenic presentation. Although not all of the specifics of these mechanisms were covered, the differences of activation are what's most important. Remember, the associated proteins and what each is able to present is most important. Flash quiz. What protein binds to CD4 positive and TCR receptors? That would be MHC2 complexes. So, in this video, we learned that major histocompatibility complexes present antigens to T cells and bind T cell receptors. MHC1 and MHC2 have a variety of differences which make them unique in carrying out the messaging for different types of foreign cells, such as viruses and bacteria. Thanks for watching, and be sure to click thumbs up if you enjoyed this video.
Hi everyone, this is the lecture on HLA subtypes associated with diseases. Let's get started. So it's important to know that MHC1 and MHC2 are proteins encoded by genes referred to as HLA genes, and that stands for human leukocyte antigen. MHC1 is encoded by HLA-A, HLA-B, and HLA-C. MHC2 is encoded by HLA-DP, HLA-DQ, and HLA-DR. Sometimes the body may attack its own cells if the MHC1 and 2 receptors too closely resemble foreign pathogens. Can you guess what examples of HLA genes are associated with certain diseases? Well, we're about to find out. Can you recall what disease is associated with HLA-A3? Yep, it's hemochromatosis. Now the mnemonic for it is to spell it like the British spell heme, so H-A-E-M, with the 3 standing in for the E, just like in Haemophilus. Hemochromatosis is an autosomal recessive disease, most commonly caused by a C282Y mutation on the HFE gene on chromosome 6. There's some high-yield biochem and genetics for you. Can you remember the classic triad of hemochromatosis? You're right if you said cirrhosis, diabetes, and skin pigmentation. This is commonly referred to as bronze diabetes. Here in this image, we can see hemosiderin, or iron, on this liver biopsy, stained with what? That's right, it's Prussian blue. Other organs that are affected by iron accumulation are the heart, the testes, and joints, and can cause restrictive or dilated cardiomyopathy, hypogonadism, or arthropathy. With all this organ involvement, do you know what a common cause of death is for people with hemochromatosis? You're right if you said hepatocellular carcinoma. And how do we treat it? We need to get rid of that iron, so we can do repeated phlebotomies or chelate that iron. With what? Deferasirox, deferoxamine, or defereprone. Fe stands for iron. So it's like we're trying to delete that iron. Now, moving on, do you know what disease is associated with HLA-B8? You're right if you said Addison's disease, myasthenia gravis, and Graves' disease. Our mnemonic for this is a little silly quote. Don't be late, Dr. Addison, or else you'll send my patients to the grave. So be late should remind you of B8. And as you can see in red, it reminds you of Addison disease, myasthenia gravis, and Graves' disease. I'm sure you're familiar with Graves' disease, since it's the most common cause of hyperthyroidism, and myasthenia gravis, because it's the most common neuromuscular junction disorder. But what is Addison disease? You're right if you're saying it has to do with adrenal insufficiency. Common symptoms of adrenal insufficiency are what? Weakness, fatigue, and orthostatic hypotension. There can be primary, secondary, and even tertiary adrenal insufficiency. Do you know which one Addison disease falls under? You're right if you said primary. It's due to a problem of the adrenal glands themselves, and Addison disease is the chronic form of primary adrenal insufficiency due to adrenal atrophy or getting destroyed by a disease. So what about HLA-B27? You're right if you said psoriatic arthritis, ankylosing spondylitis, IBD-associated arthritis, and reactive arthritis, which we commonly abbreviate as PAIR. These are also known as the seronegative arthropathies. Psoriatic arthritis is associated with skin psoriasis and nail lesions, which are often asymmetric, as you can see in this image. The patients often present with dactylitis, also known as sausage fingers, which shows on X-ray as a pencil and cup deformity that you can see in this image. Can anyone tell me what this picture is showing? Yes, this is showing a bamboo spine, or vertebral fusion in ankylosing spondylitis. Ankylosing spondylitis is associated with uveitis and aortic regurgitation. But if you have decreased mobility of your spine because the joints are fused, what else can you have? You're right if you said restrictive lung disease. You can actually tell how severe the disease is based on how well you can expand your chest wall. Well, what about HLA-C? You're right if you said psoriasis. In this image, we can see papules and plaques with some silver scaling on the hand. But in this image, do you know what the arrow is pointing to? You're right if you said the auspis side. There's spots of bleeding that can happen when the scales get scraped off and you've exposed the dermal papillae. Well, I think that's enough for the MHC1 HLA subtypes. Let's move on to the MHC2 HLA subtypes. And again, they're HLA-DP, DQ, and DR. Can you tell me what HLA-DQ2, DQ8 is associated with? You're right if you said celiac disease. The mnemonic for this one is one of my favorites, just because I really like ice cream. I ate too much gluten at Dairy Queen. So just remember 8 with the number 8 and 2 as the number 2. And the abbreviation for Dairy Queen is DQ. Now gluten is in the mnemonic too because celiac disease is gluten sensitivity. We can see from this image that there is villus atrophy and crypt hyperplasia. So we've got villus atrophy here and crypt hyperplasia. Can anyone tell me what this other image is? You're right if you said dermatitis herpetiformis, which can be a physical exam finding in patients with celiac disease. Another very high yield association you should know is that patients with celiac disease have a moderately increased risk of malignancy. Do you know what that malignancy is? Yes, it's T-cell lymphoma. Moving on to HLA-DR2. Do you know what that subtype is associated with? Yes, it has a few associations. Multiple sclerosis, hay fever, SLE, and Goodpasture syndrome. Well, let's talk about multiple sclerosis for a bit. It's an autoimmune inflammation and demyelination of the central nervous system, and it can present with a bunch of different findings. One finding can be intranuclear ophthalmoplegia, which is when the affected side of the eye can't adduct while the other eye is abducting. So the unaffected eye will have nystagmus. Can you remember where that lesion is? Yep, it's the medial longitudinal fasciculus, or MLF. As much as multiple sclerosis has a lot of neurorelations, it's also great for questions in pharmacology. How do we treat acute flares? You're right if you said IV steroids. What about refractory multiple sclerosis? Well, we can use natalizumab, which targets the alpha-4 integrin and affects white blood cell adhesion. However, do you know the major risk with natalizumab? Well, there's an increased risk of PML, or progressive multifocal leukoencephalopathy, in patients with the JC virus. See, this is how a neuro question becomes an anatomy, pathology, immunology, microbiology, and pharmacology question, which board exams love to do. Well, what about Goodpasture syndrome? It's associated with which type of glomerulonephritis? Yep, you're right if you said rapidly progressive or crescentic glomerulonephritis. Do you remember what the autoantibodies are against? Yep, they are anti-basement membrane antibodies. Now again, remember, for HLA-DR2, it is multiple sclerosis, hay fever, SLE, and Goodpasture syndrome, and our mnemonic for that is that multiple hay pastures are dirty. Can you tell me what HLA-DR3 is associated with? Well, you're right if you named some of these. Diabetes mellitus type 1, SLE, Graves' disease, Hashimoto thyroiditis, and Addison disease. Since both HLA-DR2 and HLA-DR3 are associated with SLE, the mnemonic is 2-3-SLE, which has a nice rhyme and rhythm to it. Now, what about HLA-DR4? It's associated with rheumatoid arthritis, diabetes mellitus type 1, and Addison disease. We've mentioned diabetes type 1 and Addison disease a few times now, but rheumatoid arthritis is new. So a good way to remember this is to know that there are 4 walls in a room. Can anyone remember the names of these deformities in rheumatoid arthritis? Yeah, the one on the left looks like a swan neck, and the one on the right looks like you're trying to button up a shirt. So they are the swan neck and boutonniere deformities, respectively. Lastly, what about HLA-DR5? It's associated with Hashimoto thyroiditis. And the way we can remember that, since we also mentioned it previously, is that Hashimoto is an odd doctor. So the odd DR numbers that we've talked about are 3 and 5. So HLA-DR3 and DR5 are for Hashimoto. Now, I don't know about you, but that was a lot of information. Here it all is together on one slide. Unfortunately, it's one of those tables you should memorize, and there's really no easy way to go about it, but I hope this video helped. That's all I have for you. Thanks for joining me. If you have any feedback or questions, please click on the thumb icon and submit your comments or questions there. Thanks.